So today we're going to start talking about blood. We're going to talk about blood today as well as Thursday. And then on Tuesday next week, we're going to get into some of the cardiovascular system. The cardiovascular system is pretty straightforward. Nothing really too crazy. I don't think we're going to probably take the entire duration of class to go over the cardiovascular system. So if we have time, then we'll go ahead and do a little bit of a crash review to go over all the different hormones you need to know for the test, as well as components of today and Thursday's lecture for the exam. Right on. So, anyone in here squeamish with blood? Anyone? Have any of you worked in a clinical setting yet? Oh, that's awesome. Doing what kind of work? CNA? Nice. Which one? MA? Good. All right, so you guys have seen like stuff in the clinic. The first time I saw blood in a clinical setting, I was shadowing a doc during my undergrad years at ASU. And I was helping my supervisor remove a sebaceous cyst from a patient's head. And then halfway through the procedure, all of them looked at me. They're like, "Are you okay?" Because I started like turning pale. I didn't even know that I was like about to faint, but they could see it because I was like all of a sudden going into like some sort of autonomic reaction. And so I excused myself embarrassingly and almost felt a little nauseous. I didn't quite get sick, but it was unsettling. I didn't realize that I would do that. And that was the first and last time that ever happened. So I don't know if you guys get squeamish at all, but if you do, and that's how it is for you, you're probably in the wrong field. You could probably go into behavioral health. You don't see as much blood there, but every other field, you're probably going to see blood every now and then. So let's talk about blood and get into it. And that is frozen. Let me unfreeze the screen. All right. So this is an overview of everything we're going to go over. Any metalheads in here? Yeah, sort of. Which is your favorite album of Metallica's? Master of Puppets? One. That's I think that's Injustice for All. Yeah, that's a good one. This one's my favorite one. Anyways, good times. So these are all the different components that we're going to go over. We're going to go over the composition of blood, what it's made of, plasma, all the formed components like red blood cells, white blood cells, etc. We're going to talk a little bit about what a hematocrit means. Pretty straightforward. We're going to talk about the physical properties of blood, including like the chemical properties, right? So hemoglobin, which is, of course, the active ingredient of blood, right? That's what allows for the carrying of oxygen throughout the circulatory system. We're later on Thursday, we're going to talk about different blood types, right? Type A, type B, type AB, type O, and what those mean when it comes to things like transfusion reactions, right? So if you don't do proper blood typing, that can be extremely detrimental to the patient, right? So they'll have like this immunologically mediated transfusion reaction. It's very, very deadly. We're also going to talk about rhesus classification system for like pregnant mothers, for instance. And then later on, we're going to talk about platelets, clotting factors, things like that, things that allow for us to maintain homeostasis, right? If you have a cut or a bleed, the way that your different clotting factors come in to help create a blood clot. Cool. So here's the cardiovascular system in an overview, in a nutshell. It's going to be made up of your heart, right? So it's going to be the pumping organ. Then we have the conducting system, blood vessels, and then we actually have the medium itself. So with all that combined, blood is actually considered a connective tissue of sorts. And blood is going to serve multiple different functions, which we're going to go over. It's not just carrying oxygen and carbon dioxide. It's not just carrying like things like hormones, but it's also going to be involved in maintaining temperature, things like that, transporting waste, etc. So let's go over some basic terminology. Now, if you ever see the prefix, these are all prefixes. And, oh my God, what the hell is it called for something that's not a prefix? I just had a brain fart. Anyways, so before the word, anti would be against, right? Hemo or A would be another term for blood. Erythro is going to be red, so like erythrocytes, right? Cyte is always going to be cells. And then leuco is going to be white, so leukocytes are going to be your white blood cells. Thrombo will be clot, so like if you had like thrombocytopenia, that means you do not have enough platelets or thrombocytes. And then cyte is going to be cell. Penia, not enough, like thrombocytopenia. Osis is going to be too many, so like thrombosis. That means you have too many platelets that are going to cause a clot. Stasis is going to be the ability for you to halt things like bleeding. And then oesis. So, for instance, hematopoiesis, when we actually create new red blood cells. So, erythrocyte, red blood cell, leukocytosis. What does that mean? Too many white blood cells, right? When would you get leukocytosis? Infection. Yeah, cool. And we're going to talk about the different leukocytes and what type of infections they're specifically associated with. So, for instance, if you see like a spike in neutrophil count, you're thinking the patient potentially has a bacterial infection. A spike in lymphocytes, you're thinking maybe like a viral type infection. So we're going to talk about those different cell types and what they're implicated in. What's thrombocytopenia? Yeah, you don't have enough thrombocytes. Right, exactly. Cool, so this is a summary of all the different functions of blood, right? So some of the major things that blood does is transporting substances, right? It's going to be transporting oxygen, carbon dioxide, it's going to be transporting hormones, it's going to be transporting wastes, etc. It's going to be very heavily implicated in maintaining our pH, right? So if you're acidotic, that means that you have a low blood pH. If you're alkalotic, that means you have a higher blood pH. Okay, so pH balance is going to be done a lot through the blood to act as a buffer. You're also going to see clotting factors. You're going to see leukocytes, right? Leukocytes are going to help to fight off infectious agents, foreign invaders. You're going to see stability of your body temperature as well. We're going to talk about what that looks like in a couple moments here. And this is basically the same thing, summary of all the things that are transported, right? So things like carbon dioxide, oxygen, etc. So let's talk a little bit about the different spaces in your body. So you have your circulatory system, which is going to be intravascular fluids. And then outside of your circulatory system, you're going to have the interstitial space. So interstitial fluids are going to be found outside of the cardiovascular system. And then once you get outside of the interstitial fluids and you get into actual cells, that's when you get into intracellular fluids, right? And so we're going to talk about the importance of certain proteins in your blood that help to maintain osmotic balance, right? So for instance, albumin is going to be a really important protein in your plasma that's going to help to maintain those fluid balances, right? If you don't have enough albumin in your circulatory system, then you're going to have a lot of fluids escaping the intravascular space and then entering into the interstitial space, resulting in things like edema as well as ascites. Okay, so we're going to talk about that in a little bit once we get into albumin. So blood is indeed a connective tissue. One of the major components of blood in terms of its volume and its percentage is going to be plasma. So plasma is going to make about like 55% of your total blood volume. And plasma is going to be mostly made up of water, but it's also going to have a few other things too. So plasma, we're going to talk about a little bit later, it's going to have like different types of proteins like albumin. You're also going to find things like immunoglobulins. Immunoglobulins are going to be what are implicated in fighting off like infectious agents, foreign invaders. Now, when we talk about formed elements, there's going to be three major formed elements in blood. There's going to be platelets, white blood cells, and red blood cells. Of the formed elements, the majority are going to be made up of red blood cells. And so if you do a blood draw on a patient and you put that test tube into a centrifuge and you spin it around, all those formed elements are going to sink to the bottom. And once they sink to the bottom, we refer to that as the hematocrit, right? So the red blood cells are going to be what we call the hematocrit, and it's going to be the total percentage of red blood cells compared to the rest of the total amount of blood volume. So on average, depending on the person, the hematocrit can be anywhere between like 40 to 45. There's going to be some different factors that play into that. For instance, whether or not the patient is a male versus female. Those are all going to have different impacts on the actual percentage of the hematocrit, right? As well as certain types of anemia can affect the hematocrit level as well. So we're going to talk about all that later on. So the majority of that formed element is going to be red blood cells, but you're also going to get leukocytes as well as platelets. And leukocytes plus platelets are going to make like less than 1% of your formed elements. So in other words, you have way more red blood cells than you do leukocytes. Now, I don't know if you guys, I think I asked you guys if you have taken microbiology yet. Once you do take microbiology in lab, you're going to be looking at peripheral blood smears under a microscope. When you look at a peripheral blood smear, the majority of the cells you're going to see are red blood cells. Every now and then, you're going to see like a little blip, and it's probably going to be a leukocyte. If it's really tiny, it's going to be a platelet. Platelets are much smaller than red blood cells, but leukocytes are going to be larger than the red blood cells. But in terms of percentage, you're going to have far fewer leukocytes than RBCs. We kind of already covered this here. So here's your plasma. Plasma is going to be around 55%, depending on the hematocrit level, right? It also depends on how much, if the patient's dehydrated, overhydrated, all those things can have effects on the volume of plasma. So the majority of plasma is going to be made up of water, okay, over 90%. You do have some solutes, and then you have plasma proteins. And we're going to go into all the different plasma proteins momentarily, some of which are going to be albumin, immunoglobulins, etc. And then formed elements, majority red blood cells, and then you have less than 1% of both leukocytes as well as platelets. And now I just remembered what it's called for the portion of a word that's afterwards, the suffix, right? So prefix versus suffix. Brain sucks sometimes. All right, so we kind of already talked about this in general, but let's go into some more details here. So plasma on the left side here, and then you have your formed elements on the right side. So if your plasma, majority is going to be water, right? And what water acts as is going to act as a solvent. So it keeps all the blood in solution. And then you're also going to have a lot of different ions in your blood. I'm going to show you a chart of what the normal ranges of different ions are. For instance, potassium, sodium, chlorine ions, things like that. So you'll be able to see like the normal ranges. If you get like ion imbalance, for instance, a patient might have like hypernatremia. They have like too much sodium, or they might be hyperkalemic. They might have too much potassium, or hypokalemic. So those are all different ions that you have, and they generally need to stay within a certain balance. Otherwise, if you get ion imbalance, it can result in all sorts of different complications. So, for instance, like cardiac arrhythmias can come about as a result of ion imbalance. If you have an imbalance of potassium or sodium, you can also have problems with conducting a nerve potential, right? So potassium and sodium is going to be heavily implicated in that. So if you have ion imbalance, you need to correct that in a clinical setting. And then plasma proteins, the major plasma protein is albumin. You also have things like fibrinogen, which is going to help to form clots. You also have immunoglobulins, and immunoglobulins are going to be predominantly implicated in fighting off infections, right? And you have other substances as well that are being transported to, such as oxygen and carbon dioxide. And then as far as your cellular elements or formed elements, you have different cell types, erythrocytes or RBCs, white blood cells, and then platelets. We're going to go into all those in a little bit here. So from your formed elements, just to recap, erythrocytes are going to be the most predominant of all of three of those formed elements. White blood cells, not as predominant, but they're going to be there to help fight off infections. And then platelets or thrombocytes are going to be associated with blood clotting. Okay. All right. Let's talk about some things that blood, like some of the characteristics of blood. So blood is very viscous. It's going to be 5 times as viscous. So blood is much thicker than water. In terms of temperature, I had to issue a correction on this. There was a typo before. The other slide that you guys probably got earlier this week. Oh yeah, by the way, I forgot to tell you. Like, I just uploaded the new slides about 10 minutes before class today. So you guys should have the new slides. And I'm going to do another update for the remainder of the chapter, probably by the end of tomorrow. So the original slide said 38 degrees Celsius or 100.4 Fahrenheit. What happens when you have 100.4 Fahrenheit? What does that mean? You have a fever, right? So the patient is febrile. 100.4 and above is actually a febrile patient. By the way, one thing that you guys are probably going to hear in a clinical setting is this silly term called a low-grade fever. You're either febrile or you're not febrile. It's one or the other. You don't just have a low-grade fever. Once you get to 100.4 Fahrenheit, that's when you can say that, yeah, the patient has a fever. Okay. I don't know why. I was in the hospital with my wife like 5 months ago, and I would hear the nurses and all the other people talking about low-grade fever. That's like a weird term that we don't really use. It's not very proper. But anyways, so 37 degrees Celsius is going to be your average body temperature. 98.6 degrees Fahrenheit is going to be the average body temperature in Fahrenheit. In terms of the pH balance, a good rule of thumb is 7.4. Okay, 7.4 is kind of like the average pH. Okay. But there's a reference range, right? It can be anywhere between 7.35 to 7.45. That's all normal, right? Nobody's going to be like perfectly at 7.4. But if they get beyond 7.5, then the patient is going to be alkalotic. They're going to have alkalosis, okay? And then if they're going to be below 7.35, that means the patient is acidotic or they have acidosis. If they are acidotic, maybe they're going through like, I don't know, respiratory depression. Take, for instance, a drug overdose, right? A patient ODs on fentanyl. One of the major things that kills a patient that ODs on fentanyl is respiratory depression. It slows their breathing. What happens when they slow their breathing? Not only are they not bringing in oxygen, but they're also not breathing out carbon dioxide. So when carbon dioxide accumulates within the blood system or the bloodstream, then you go into acidosis, okay? And that can have lots of different complications, but generally speaking, if you're not getting oxygen to begin with, you're in pretty bad shape. And then we're going to talk about carbon dioxide or carbon monoxide in a little bit. That's another severe case that can interfere with your oxygen levels. In terms of men versus women, guys on average are going to be slightly larger than women. So because of that, you're going to have a little bit more blood for guys than for ladies. Guys are going to be anywhere between 5 to 6 liters. And for women, it's going to be anywhere between 4 to 5 liters. These are averages, right? There's always going to be exceptions to the rule. Nothing is set in stone. Another thing that we're going to talk about later on, but why do sometimes women have a lower quantity of blood? Menstrual cycle, yeah. So women within reproductive age are generally going to run slightly anemic, but some women are going to have heavier menstrual cycles than others. And so those individuals are generally going to have a lower hematocrit in terms of percentage, and they're going to run a little bit anemic. It's very common. I know a lot of people that have that, so it's nothing really too startling or out of the ordinary. Cool, so let's talk about hematopoiesis. So remember that suffix poiesis, that's going to be the creation of, right? So you can have erythropoiesis, that's going to be the production of erythrocytes. You can have leukopoiesis, and you can have thrombopoiesis, depending on what kind of cell type you're producing, right? So let's talk about the progenitor cells. So there's going to be 2 predominant categories of progenitor cells. They're going to be either myeloid or lymphoid type stem cells. Okay? So myeloid stem cells are going to be what produce the majority of your blood cell types. Okay? So From myeloid cells, those are going to not only make red blood cells, they're also going to make mast cells. They're going to also make myeloblasts. And of those myeloblasts, that's when you get the production of your granulocytes, as well as one type of agranulocyte. So all three granulocytes are going to be coming from myeloblasts, so basophils, neutrophils, eosinophils, and then you're going to have one agranulocyte, which is monocytes. And monocytes can eventually turn into either macrophages, which just do boring old phagocytosis, or dendritic cells, which are a little bit more interesting. Dendritic cells are going to be found in regions like the malt. I don't know if you guys heard about that, in Peyer's patches. It's going to be like mucosal associated lymphatic tissue that you find in your GI tract. And what dendritic cells do, they have those little finger-like projections that extend out into the environment. And what they do is they try to capture little antigens from the environment, potentially pathogenic antigens. And what those guys do is that they become antigen-presenting cells. Okay? Have you guys ever heard that term before? Okay, so you'll learn about that microbiology later on, but let's just overview that real quick. An antigen-presenting cells takes an antigen and then it presents it to a T cell lymphocyte. So it can either present it to a helper T cell, which would be one of these guys, T lymphocytes, and the helper T cell will activate macrophages to go off and like do its dirty work and kill foreign invaders, whether it's like a bacteria or like a virus or something like that. They could also activate cytotoxic T cells. And cytotoxic T cells, when they get activated, they're going to release what we call tumor necrosis factor. And what they do is that they induce apoptosis into cells that are infected with viruses, or maybe they're damaged for whatever reason. So, for instance, like cancer cells, cytotoxic T cells will actually help to kill cancer cells as well. So that's what dendritic cells do. They're really cool. They have a huge role in cell-mediated immune system. So don't worry about that for this class, but just know that dendritic cells are pretty cool. And then another cell that's going to be coming from myeloid progenitor cells will be your megakaryocytes. And these megakaryocytes are going to be chilling in your bone marrow, and they're just going to basically slough off platelets. That's all they do. So those are all going to be your myeloid progenitor cells. Then for your lymphoid progenitor cells, think lymphocytes, okay? And lymphocytes are going to be the second of your agranulocytes. By the way, that term, do you guys know you guys heard of that term granulocyte before? You guys never heard that term? Oh, okay, sorry, I probably should have gone into that. So granulocytes literally have granules, okay? They have like, if you can see on the image here, like the basophil, for instance, it's like got these little speckles all the way around it. So those are called granules. And depending on the cell type, they're going to have granules that contain specific substances that get released depending on what their activity is, right? So basophils, for instance, are going to be associated with histamine release. You guys know what histamine does? So like allergic reactions, right? So if you take like diphenhydramine or, I don't know, sertraline or something like that, cetirizine, those are called antihistamine drugs, right? And so you take an antihistamine so you can try to reduce the effects of your allergies. But what neutrophils do, they can undergo like oxidative burst, they can release all sorts of things that are specifically targeting bacteria. And then eosinophils are going to have granules that are going to specifically target things like helminths, so like parasitic type infections. Okay, so those are granulocytes. You can when you look at a peripheral blood smear, you'll be able to see the granules on the peripheral blood smear. Versus the agranulocytes, they don't have granules, they're just smooth. And the two major cell types that fit into that category are going to be monocytes that can turn into macrophages or dendritic cells, or lymphocytes. Okay, so monocytes and lymphocytes are going to be two of the major agranulocytes. So 0 granules to be released. In terms of production, you're producing cells in really high numbers every single day. So 400 billion platelets, 200 billion RBCs, 10 billion white blood cells. So these are constantly being produced in extremely high numbers. As a matter of fact, RBCs, red blood cells, are some of the most widely produced cell types in your body. So very important, right? Critical for your everyday functioning. So let's talk a little bit about myeloid versus lymphoid hematopoiesis and where it takes place. So for those myeloid progenitor cells, most are going to be produced in the bone marrow. So bone marrow, so RBCs, platelets, white blood cells. In terms of the white blood cells, however, lymphocytes are going to be a little bit different. Lymphocytes are going to be associated with lymphoid hematopoiesis, so that's going to be taking place in the spleen, lymph nodes, thymus, tonsils. In terms of your thymus, think T cells, okay? So that's one thing to keep in mind. And then you don't have to know exactly where all these cell types are being produced. This is beyond the level of this class, but it's kind of fun to look at where these cells would be produced, either in the fetus or after birth. So before birth, a lot of your hematopoietic tissue is going to be taking place in the liver. So the liver is going to be one of the major producers of blood. Okay, a little bit in the spleen as well. And then, as you're about to be born, then it switches over to bone marrow. And then bone marrow from then on becomes one of the more predominant areas where you get hematopoiesis. And then different regions are going to be associated with different age brackets. So as you get a little bit older, the marrow in the femur, as well as in the tibia, they're going to become less prominent, right? So in other words, hematopoiesis is mostly going to be taken up by, for instance, the vertebrae, sternum, ribs, etc. So it kind of switches over time as the individual gets older with age. Now let's talk a little bit about plasma. Any questions so far? Cool. So let's talk about plasma. Plasma, as I mentioned already, is going to be mostly made up of water, right? That water is going to be a solvent. It keeps everything into solution. As for the actual other components, proteins are going to be some of the most important components of plasma. Of those, albumin is going to be like number one. It's going to be your top plasma protein. And albumin is going to be associated with a lot of different things, especially osmotic pressure, right? If you do not produce albumin, you're going to get swelling, edema. You might also see ascites. We're going to talk about what ascites is, and I'm going to show you a little video of a paracentesis, which is the removal of ascites from the peritoneal cavity. Then you also have globulins, antibodies, immunoglobulins are basically the same thing. Those are going to be associated predominantly with immunity, right? Different types of immunoglobulins are going to be associated with different areas of the body. So for instance, you have different immunoglobulins like IgG, IgA, IgD, IgM. Those are all going to be different immunoglobulins that are associated with different functions. And then you have fibrinogen, which is going to be associated with clotting. And then in your plasma, that's where you see all of your other solutes. So one of the most important things are going to be electrolytes, right? So that's what helps to maintain your electrolyte balance, as well as wastes. So urea is going to be a byproduct of the breakdown of amino acids. So as amino acids get metabolized, they get broken down, get turned into urea, and then get excreted through the kidneys. And then hormones as well as gases. So you guys don't need to commit any of this to memory. I just included this. This is from your guys' textbook, but it gives you a good idea of reference range for different ions and different components of the blood. So let's take a look at the electrolytes up here. So sodium, number one, that's going to be one of the most abundant of all the electrolytes. If you have too much sodium, the patient becomes hypernatremic. If they have too little sodium, hyponatremic or hyponatremia. Then you calcium levels, potassium. Once you get into clinic and you read your patient's charts, generally speaking, labs will give you the reference range, the normal lab values, but then they'll highlight the ones that are abnormal. But you usually don't have to commit these to memory, but it's kind of good to have a general feel of what's normal. So when I was, doing clinical work, I would always remember 140 is kind of the average for sodium. I would always remember calcium as 10. 10 is about the average. Potassium, I would remember 4. 4 was kind of the average. So you'll get used to this over time once you start seeing patients more and like reading their lab charts and whatnot. Let's see, other things here that are important. Where's albumin? So triglyceride levels. So these are going to be really important in monitoring your patient's cholesterol levels. So you have a couple different types of cholesterol. You have your HDL, LDL, triglycerides. So if a patient has really bad cholesterol, usually they're going to have an elevation of triglycerides or LDLs. LDLs, we usually refer to them as like the lethal type, right? LDL, but it's actually low density lipoproteins. HDL means high density lipoproteins. Those are what we consider the healthy cholesterol. So if a patient has like really high HDLs, you don't have to really worry about too much. If their LDLs are really through the roof, then they're going to be predisposed to things like atherosclerosis, heart attacks, myocardial infarction, stroke, things like that. So this is just a good reference point for you guys in terms of regular values in a patient. So immunoglobulins, or just globulins, those are going to be produced by plasma cells. Now, I didn't include that. Well, I did include that in here. I was going to ask you guys, do you guys know where plasma cells come from? So you have two major categories of lymphocyte. You have your B cell lymphocytes and you have your T cell lymphocytes. Now, for your B cell lymphocytes, B cells are going to fall under the category of your humoral immune system. Do you guys remember what the term humors mean? It comes from like ancient medicine. If you read like Hippocrates and like all those dudes from like 2,000 years ago, they used to talk about the four humors. You guys ever heard of like green bile versus black bile versus, I can't remember off the top of my head. But they thought if somebody was sick, it was like an imbalance of those humors. But that term still stuck. Humors mean fluid, okay? So if we talk about the humoral immune system, we're talking about like B cells that produce immunoglobulins. And immunoglobulins are specifically going to be produced by plasma cells. When a B cell gets activated, right? So for instance, like an antigen-presenting cell presents an antigen to that helper T cell, then the helper T cell goes off to activate the B cell. Then the B cell is going to eventually differentiate and proliferate. And once it does that, it becomes a plasma cell. And once it becomes a plasma cell, it's going to start secreting specific types of immunoglobulins that target specific antigens. Okay, that's why I included this chart up here on the top, so you can see how a naive B cell, once it gets activated, it turns into an activated B cell, aptly named, and then it becomes a plasma cell. And it's going to release all different types of immunoglobulins, just depending on what exactly it is that they're trying to target. There's also going to be transport globulins. So some of those are going to be like transferrin. So transferrin helps to like carry metals in your blood. You're also going to have those apolipoproteins, right? Those are going to carry like cholesterols. So they can carry triglycerides. They can also carry things like proteins. LDL, that's going to be the bad one, lethal, right? So low density lipoprotein versus the high density lipoprotein. You're also going to have steroid binding proteins as well. So those are all going to be different globulins that you find within your plasma. So let's talk a little bit about albumin. So I already mentioned that albumin is going to be arguably the most important of your plasma proteins. It's going to be involved in a lot of things. So it acts as a carrier protein by and large. So it's going to help to carry things like thyroid hormone, steroid hormone. It can carry calcium, bile, things like that. And here's a little question for you as a recap. What is it called when you have a hormone that is attached to a carrier protein? It's bound, right? Versus free. Good. Excellent. And you can give albumin exogenously. So we're going to talk about patients that have like liver cirrhosis. So if a patient has liver cirrhosis, their liver fails, they can't produce albumin. That's where albumin is produced. So raging alcoholics such as myself eventually will not be able to produce enough albumin. And so if you do have a patient with cirrhosis, you can actually provide them with exogenous albumin just to try to overcompensate for that. So I'll show you why that's important in a second here. So your plasma proteins are mostly going to be made in your liver. Yeah, I wouldn't recommend doing what this dude does. Did you guys hear about the recent controversy with him? Have you guys ever heard of this dude? You haven't heard of Liver King? All right, so Liver King, he's like this guy that just like eats everything. It's like really gross. He'll eat like liver, he'll eat all sorts of weird stuff, and he'll eat it raw. And like, he's like, yeah, that's how I got so ripped and jacked. And then finally it turns out that like he was taking anabolic steroids. Like, yeah, duh. And so he had to like issue a public apology. He's like, I'm so sorry to all my followers. I didn't mean to like misguide you. I'm actually just taking steroids. Anyways, kind of funny. Anyways, huge digression. So if you do not produce proteins properly because of liver failure, aka cirrhosis, something like that, then you can get all sorts of different conditions, right? You're not producing like clotting factors, you're not producing albumin. Does anyone know what this condition is called right here? All those little red tiny stipples. What does it look like is happening right there? What's causing this? Is that a person with a really bad case of freckles, or is something else happening there? What do you think those red stipples are actually made of? Huh? Blood, yeah. So what's going on? Those are like, what's going on? It's like it's bleeding, right? Those are like little tiny microvascular bleeds. That's referred to as petechia. So petechia are these tiny little stipples of bleeding that can happen. Lots of different conditions can cause that, but a really huge condition is liver failure because you're not producing clotting factors properly. If you don't produce clotting factors, you're going to start bleeding out. Okay? Other things can cause this too, like meningococcal meningitis can cause this. So you can get other conditions that can cause petechia. But if you have liver failure, you can also get petechia as well. So this is what ascites looks like. You can also see this kind of similar presentation in other condition, another condition too, specifically. Have you guys ever heard of kwashiorkor? You guys never heard of kwashiorkor before? It's probably because we live over here. We have an overabundance of food. But in regions of the world that are like deficient in food, often like war-torn countries, places that are undergoing famines, right? You'll see those little pictures of kids. They're all scrawny, but they have like massive distended bellies. They look like they're overfed, but they're actually not. They're starving to death, right? They're starving to the point where they don't have enough protein in their diet. Because of their lack of protein in the diet, and all of a sudden they're not able to produce other proteins like albumin, right? And so because of that, they get ascites, which is like a massive fluid shift from the circulatory system into the interstitial space, specifically the peritoneal cavity. And so that's ascites. And you can see it in alcoholic cirrhosis as well. Other cirrhosis can cause it too. Like, you guys know another popular cause of cirrhosis? Caused by the most common blood-borne illness. Any ideas? There's one virus that causes the most common blood-borne illness. It involves your liver. What's another name for liver cells? Dang, sorry. Okay, so hepatocytes. So we refer to as liver cells as hepatocytes. So hepatitis. Okay, so hepatitis C is the most common blood-borne illness. So it's a virus, hepatitis C virus. And hepatitis C, it generally becomes chronic over time. So if you have chronic hepatitis, eventually the patient develops liver cirrhosis. And then after liver cirrhosis, it actually predisposes them to getting hepatocellular carcinoma. So they'll get liver cancer over time. Hepatitis B does the same thing too, but only in 20% of patients. The rest usually recover from Hep B. But so alcoholism is going to be one of the most common causes of liver cirrhosis, but you can also get that from hepatitis as well. If you do get hepatitis, you're not going to get, and by the way, MCC means main cause. Pathophysiology. So you have reduced albumin, you have reduced oncotic pressure. Because you remember, with osmosis, water follows solutes, right? If you don't have albumin, you're going to have fewer solutes in your bloodstream. That means water is going to escape. It's going to leave the circulatory system, and it's going to enter into the interstitial space. All right, so you get like a little bit of a fluid shift. You have fluid moving from one region to the other. And then you get edema, and you get ascites. So this is a video of paracentesis. I had a hard time finding good ones of paracentesis. So I found this one. It's pretty decent. It's more like a tutorial for surgeons. But regardless, I think it's kind of interesting. So I'm going to skip forward to right here. Kind of cool, huh? Now, the thing about that, if a patient does have cirrhosis, they need to go in there and do this frequently. Because, of course, the ascites is going to come back with time, right? So that's not a cure for it. It's just a therapeutic treatment, right? So the patient's going to have to do that periodically, unfortunately. So let's talk a little bit about the hematocrit. So the hematocrit basically is just the percentage of red blood cells in the total amount of blood, okay? So if you have, I don't know, 20% red blood cells because you're like bleeding out, or maybe you like drank way too much water. I don't even think that's really possible to get that low of a hematocrit from drinking water. But say you did 20% red blood cells, your hematocrit would be 20%. Okay, so it's just a percentage. Nothing really too crazy. And the way that you get that percentage is you do a blood draw, you send that blood sample to the lab, they put it into a centrifuge, they spin it out, and then everything that sinks down to the bottom, that's going to be the hematocrit. Newborns are actually going to have a pretty high hematocrit compared to full-grown adults. But when you do see full-grown adults, it's normal to see guys having a higher hematocrit than ladies. And guys, on average, 45%. If you start getting above 54%, that's really bad. That's really dangerous. Some patients that get up to that high level of hematocrit, they will start seeing things like blood clots. So what do you think a good treatment for that would be? Yeah, absolutely. So bloodletting, therapeutic phlebotomy. So the bloodletting that people used to do like 500 years ago, under certain circumstances like that, it would actually be beneficial. For the most part, bloodletting is not the greatest treatment for different ailments. But for ladies, hematocrit is going to be slightly lower. So, oh yeah, and then if a patient is pregnant, you're going to see a decrease in their hematocrit. So, yeah, and plasma concentration during the third trimester is going to be elevated. So you'll see a little bit of a decrease during the third trimester. Oh yeah, so these are some of the causes, right? So if you have a really high hematocrit, you might have reduced amount of plasma, right? So your red blood cells don't actually change. It's just that the plasma level has dropped. Okay, does that make sense? So in other words, you basically elevate the hematocrit because just the sheer percentage of red blood cells is going to be greater because plasma is made up of over 90% water. Low hematocrit, anemia, bleeding out, so a hemorrhage, right? So if a patient had a blunt trauma, right? Maybe they got like a pelvic fracture, and all of a sudden, like their femoral arteries and veins are just like bleeding out. So a large amount of blood loss would lead to internal bleeding, which would obviously reduce your hematocrit. Let's talk a little bit about the red blood cell in and of itself. So the red blood cell is going to have a very stereotypical shape. It's going to be biconcave, so it's going to be concave on both sides. And the shape is actually going to change in a lot of different ways. So you might have like microcytic anemia, you might have macrocytic anemia. We're not going to go into this because this is not a pathophysiology class. But once you guys study patho, you're going to learn different types of anemia that are going to be affecting the actual shape and size of the red blood cell. But we're going to just talk about what a normal red blood cell looks like and what a normal red blood cell does. So we have a lot of red blood cells in our body, and the way that they're shaped, it's going to allow them to have a really large surface area to volume ratio. The reason why that's important is because the way oxygen and carbon dioxide gets loaded on and loaded off of the red blood cell is literally just through simple gas diffusion. So nothing really crazy there. And then in terms of size, if you look at a peripheral blood smear like this is just a drawing, so it's not really what it looks like, but this big blob right here, that's a leukocyte of some sort. Judging by this image, I can't really tell what it is. Maybe it's a neutrophil, just because neutrophils are like the most abundant ones that you'll see. What do you guys think this little tiny thing right here is? Or that little tiny thing right there? Huh? A what? Plasma? Yeah, it's a platelet. Yeah, so plasma, you don't really see it because it's mostly water, right? You do see the platelets, though. They're going to be really tiny. The little tiny blips, the little tiny specks, those are platelets or thrombocytes, right? The same term for different term for the same thing. And then good to know is that red blood cells are produced in the red bone marrow, and one of the major components is going to be hemoglobin. Now, some of the requirements for red blood cell production are going to be certain types of amino acids, but more importantly, well, iron as well, but more importantly, you're going to need certain types of vitamins too to help produce red blood cells. If you have any deficiency of these types of vitamins, you're going to have defective red blood cells. So we're going to talk about a couple anemias. Like one example is if you have intrinsic factor deficiency. So if you have intrinsic factor deficiency, you're not actually able to absorb vitamin B12. And so because of that, we get a condition called pernicious anemia. That's because the patient's not able to actually take up vitamin B12. And so because they can't do that, it's going to affect red blood cell production. And then another really important thing too is CKD. What does CKD mean? Huh? CKD is chronic kidney disease. So if a patient has like stage 4 renal failure, right? If they have chronic kidney disease, they're going to have a difficult time producing red blood cells because cobalamin, vitamin B12, goes to the kidney to get metabolized into its active form. So if you have damage to the kidneys, you're not going to be able to produce adequate red blood cells. Now, in terms of the lifespan, we talked about this already when we talked about the hemoglobin A1C test for diabetics, right? So just remember the red blood cell can live on average 120 days, but it's anywhere between 90 to 120 days. And a big thing that's important to keep in mind is the lack of a nucleus. Red blood cells do not have a nucleus. So once they get produced, that's it. They have to survive that 120 days. And then eventually once they get destroyed, or once they get damaged, or once they just reach the end of their lifespan, they're going to be broken down by the spleen, the liver, and the bone marrow. The spleen is going to be really huge in breaking down red blood cells, and then like sequestering off the different components like the heme to get recycled, etc. And then this is going to be the different stages of red blood cell production. So you first start off with that pro-erythroblast. That's going to be like the myelogenic progenitor cell. And then you have the cell just undergoing different types of changes, and eventually that nucleus gets removed, and then you have the reticulocyte, which eventually matures into a red blood cell. Okay? So, what do you think would be one of the reasons why you want to remove the nucleus of a red blood cell? It doesn't really seem to be beneficial to not have a nucleus in the red blood cell, right? There's actually some animals that do have nucleated red blood cells. Good examples are like frogs, for instance. They have nucleated red blood cells. So there's certain animals that do have nuclei in their RBCs. But those animals generally have a lower metabolic rate, right? So they're not actually metabolizing as rapidly as we do. So because of our demand for metabolism, we're going to have a high demand for oxygen. And to maximize oxygen carrying capacity, you want to make sure you cram that red blood cell with as much hemoglobin as possible. Okay? So that's going to be one of the reasons why you don't have a nucleus in our red blood cells, because you want to make sure you maximize the amount of hemoglobin. And then we already talked about the high surface to volume ratio. And then because of the shape of the red blood cell, it makes them very bendy and flexible. So they're able to actually channel through really narrow spaces, like, for instance, capillary beds, right? And so during their ability, once they go through those capillary beds, that's when you see simple diffusion of gases, right? Oxygen and carbon dioxide. When they do form these little stacks, like over here, that's going to be referred to as a redoux. Tried to be as French as possible with that one. I don't know if I succeeded. So moving on, in terms of hemoglobin, each red blood cell has a lot of hemoglobin, okay? So depending on what, reference you use, your course text says 280 million hemoglobin molecules. I did a brief Google search. Some other references say like 270 million hemoglobin molecules. But long story short, you have a lot of hemoglobin molecules per red blood cell. Each of those hemoglobin molecules can carry four oxygens. Okay, and let's see here. And then the majority of our majority of our oxygen is going to be bound to hemoglobin. And then in terms of the components of hemoglobin, it's going to be made up of two different things. It's going to be made up of both iron as well as biliverdin, which has a kind of greenish color, which we'll talk about that in a second here. Now, if the iron is bound to oxygen, you're going to have oxyhemoglobin. So that's going to be this one over here on the left. So it gives it more like a bright red appearance, right? And then if it's not bound to oxygen, then you're going to have deoxyhemoglobin. Pretty straightforward. Nothing really too crazy there. But deoxyhemoglobin is going to have a little bit more of a dusky, darkish, almost kind of purpley color, right? That's why when you see your veins, they look pretty blue-ish, right? It's not truly blue, but it has that kind of appearance when you're looking at it through your skin. So we kind of talked about the iron plus biliverdin, and then you're going to have globulins. Now the globulins are going to be made up of 4 different protein chains, and the 4 protein chains are going to be subdivided into these different chains right here. So you have both 2 alphas and 2 beta chains in hemoglobin. Okay, those are going to be the major components. You do see a difference, though, in fetal hemoglobin. Because the developing baby has a greater need for oxygen while they're developing, then you're going to have a different type of hemoglobin for babies. But I'm not going to test you on that. That's just kind of FYI. For adults, it's going to be 2 alphas and 2 betas. And do recall that you have 4 oxygens that can bind to each one of those hemoglobin molecules. So in other words, each one of those subproteins, the 2 alpha, 2 beta, each of those can bind onto a oxygen molecule. And this is kind of what it looks like. So here's oxyhemoglobin. It's got the little oxygen bound to the ferritin. And you have alpha and then the beta subunits. And then you have your deoxyhemoglobin, which doesn't have oxygen. Pretty straightforward. Now, let's talk a little bit about carbon monoxide poisoning, because this is kind of interesting. Carbon monoxide has a really high affinity for binding to hemoglobin. So if you breathe carbon monoxide, it's going to be preferentially bound to hemoglobin rather than oxygen. So, if you leave a stove on, if you live in a place that has a gas stove or something, or if you sit in your car and you put a hose through your window, that's how some people try to off themselves, right? And it's very effective because of this. It has a very high binding capacity. And then if you want to treat carbon monoxide poisoning, you're going to provide them with hyperbaric oxygen therapy. So you're going to put them on a ventilator, and you're going to crank up the oxygen level so that they can try to remove those carbon monoxide molecules to the best of their ability. So let's watch a little video about this here.
In the winter, we fight the cold by turning up the heat. We're often focused on the risk of being too cold, but we also need to consider the risk of how we're warming up. When you're burning anything like gasoline or kerosene, wood, coal, or propane for heat, carbon monoxide poisoning can pose a serious risk. Part of what makes it so risky is that CO, that's the chemical formula, is odorless and colorless. CO can give you some very severe side effects in very small concentrations. Being exposed to about 400 parts per million, that's about 0.04% of the air around you, can give you a headache and nausea. That sounds bad, but not too bad. Bump that up to 800 parts per million, and in 45 minutes, you've got the headache, the nausea, and you're dizzy. 15 minutes later, you could be unconscious. Now, what makes CO so dangerous? It's a molecular monkey wrench in our breathing process. Every cell in our body needs oxygen. This requires that O2 be transported through the body. Cells take it up, and then the cells have to use it. CO messes with all of these processes. First, let's talk O2 transport. The protein hemoglobin is tasked with finding O2 and shuttling it around. Now, O2 is a good passenger. It holds on tight, but lets go when the time is right. The same can't be said for carbon monoxide. It holds on much tighter than O2, about 200 times tighter. CO is also a bad guess, overstaying its welcome. CO's extra sticky nature means that O2 can't find its hemoglobin, and oxygen can't get to where it's needed. Want to stay safe from carbon monoxide poisoning? The CDC recommends the following. Have your heating system, water heater, and other gas, oil, or coal-burning appliances serviced by a qualified technician every year.
All right, we get the idea, right? So carbon monoxide, bad, not good. Try not to breathe it in. So in terms of hematopoiesis and homeostasis, some of the things that trigger the production of red blood cells is going to be like being in a hypoxic state. So take, for instance, if you go to a place like the Himalayan mountains, or you're going to go visit Machu Picchu, right? So it's really high elevations. A lot of people that go to those high elevations start getting like mountain sickness. They have really hard times breathing. That's why if you do a hike like that and you're going to do some like mountaineering, usually you have to go into like some training, right, to get your physical stamina up so that you can be able to actually withstand the hike. And so if you are in a hypoxic environment, you're going to force your body to try to produce more red blood cells to try to make up for the hypoxia. And one of the ways that that happens is through the production of erythropoietin. Now, erythropoietin is going to be produced in the kidneys. It's going to be produced in the kidneys, and it's going to stimulate the red blood cells. You can also take exogenous erythropoietin, which we'll talk about in a second. But to summarize, low levels of oxygen stimulates erythropoietin. Exercise stimulates erythropoietin. And even if you have like tissue damage in your lungs, right? So like emphysema, any sort of like respiratory illness, that's also going to stimulate the production of erythropoietin as well. Okay, just so you can try to accommodate and make up for the lack of oxygen being delivered to your tissues. So here is what happens when you do like exogenous erythropoietin. So you can take EPO exogenously. So that's what Armstrong over here did, the famous cyclist, and got him into trouble. A lot of sport, a lot of athletes, they get monitored for exogenous EPO because it's basically like a performance enhancing drug, right? So it's going to help you increase your stamina, increase your tolerance, right? So you can do more strenuous type exercises. Let's see where we're at, 4 o'clock. All right, cool. So, in terms of the removal of red blood cells, your red blood cells are going to have a shelf life, right? Up to 120 days. They can also get damaged from different conditions like sickle cell anemia, things like that. We'll talk about what that looks like later. But you are losing a little bit of your red blood cells every day, okay? So that's why you have to try to make up for the production of red blood cells to kind of counterbalance that. The way that the red blood cells are broken down is through like the liver, the spleen, as well as the bone marrow. Those cells are specifically referred to as Kupffer cells, and Kupffer cells are what actually phagocytose red blood cells. And once they get phagocytosed, they can be broken down and the components can be recycled for other purposes. So hemoglobin can be recycled as iron to back to the bone marrow, so you can undergo further erythrocyte production, or you can have the production of bilirubin and bile. Right? So bile is going to be really important to aid in the digestion of fats. Right? So bile gets released. You eat like a really fatty meal. Once you do that, you have the release of bile. And what bile does, it acts as like an emulsifying agent. So it's an emulsifier, so it binds those lipids so that they can be absorbed through your GI tract. And so that's going to be a derivative of heme. So here's kind of an overview of what that looks like. So here's your macrophage over here, the big blob, and it's going to be phagocytosing either the full erythrocyte or components of a damaged erythrocyte that underwent hemolysis. It's going to go, components are going to go back to the bone marrow, right? Or if it goes to the liver, it's going to be bound as ferritin. Okay, so ferritin is going to be bound iron. That's going to be seen in your liver. And then, let's see here. I kind of went over all that. It goes to the bone. Good. So let's talk about heme when you have conditions like hemolytic anemia or any sort of other issues with your liver that can result in jaundice. So biliverdin is going to be one of the breakdown components of heme. Biliverdin eventually turns into bilirubin. Biliverdin is going to be green in color. Bilirubin is going to be yellow in color. Have you guys ever got a really nasty bruise and you notice that over time that bruise kind of transforms in color? Like towards the end, as your bruise is getting healed, it's going to eventually start looking kind of yellowish in color. That's going to be the bilirubin from the blood from that bruise. Now, if you have jaundice, you're going to have yellowing of the skin. And lots of different conditions can cause jaundice. Sclera icterus is a really startling presentation of jaundice, but you can get that from liver failure, liver damage. You can also get that from a specific type of infection that's transmitted by a mosquito. You guys have any idea what I might be referring to? Huh? Malaria. Yeah, malaria. Exactly. So I had a patient when I was doing internal medicine rotation who was traveling back, visiting family from Africa. While he was in Africa, he got malaria. He actually became symptomatic on the airplane ride back. Then we went to the hospital. He had super yellow sclera, and they call it sclera icterus. Okay, so that's like jaundice that affects the yellowing of the eyes. So pretty nasty, and that's because malaria not only causes hemolysis because it affects your red blood cells, it can also damage the hepatocytes because there's two different lifespans. There's going to be the red blood cell component, and then there's going to be a hepatocyte component to the malaria or plasmodium life cycle. Okay, so if you have a lot of iron that's being sent to the liver, it's going to be ferritin. We already talked about that. And then this is going to be where you have bilirubin being sent to the liver. Now, if you have excessive amounts of bilirubin in your liver, it's going to be converted into bile, which is the emulsifying agent. And then a little bit of that bile is going to be reabsorbed. And that's going to be called urobilins. And that's going to be sent off to the kidney so that it can be excreted in the urine. And then transferrin is going to be the carrier protein, right? We talked about that a little bit earlier in terms of carrier proteins. Transferrin is going to be the major one that helps to bring excessive amounts of iron back to the bone marrow. And then once it gets stored in the liver, it's going to be stored as ferritin. Okay, so it'll be a good idea for you to know the difference between transferrin and ferritin. So we have about 15 minutes left. Do you guys want to go straight into quizzes? Yeah? Okay, so we'll go straight into quizzes and then we'll wrap up today's lecture. We'll start off on anemia. I did include some questions on the quizzes for anemia, but whatever. Let's just go ahead and get into it so we can get your guys' attendance. So, no. All right. How's it going? Good? You do? Let me see. All these over here? By the looks of it, you basically got them all covered. So nice. Did you make this chart yourself? Oh, that's cool. This is great. You should be good. That covers everything. Yep, you got all the 9 hormones from the pituitary. You got all the releasing inhibiting hormones. Thyroid, good. Got that. And then on the back, yep, that's perfect. That is it. That's all I would be testing you guys on, except for one that you guys. We're gonna get into it in GI, but like ghrelin. So you had leptin on there, which is good, but then the other one is ghrelin. But we're gonna talk about that. It's G. Oh my gosh. GHRELIN. I think it's GH. It's either GRH. I can't recall, but I learned how to I learned how to spell college when I got into college, so spelling is not my forte. Yeah, no sweat. So we have one more person to log in. Oh, there we go. Cool. All right. This one should be pretty easy. We talked about it quite a bit today. Good. Most of you guys got it right. Aminoglobulins are going to be in your plasma, but it's not going to be making up the majority of your plasma proteins. Aminoglobulins make up a pretty small percentage of your total plasma proteins. The number one is going to be albumin. So good job on that. Good. Very straightforward. Nothing too crazy. Deoxyhemoglobin. Right? Oxyhemoglobin has oxygen bound to it. Okay, next. Sounds like popcorn. Sounds like a pretty easy one for you guys. Awesome. Very straightforward. Nothing crazy. I'm going to start going harder on you guys moving forward here. They're all very easy questions. Uh-oh. We got a little bit of a spread here. All right. Hemoglobin contains all the following except. So does hemoglobin have 2 alpha and 2 beta chains? Yes. Does hemoglobin have 4 heme molecules, which are these 4 right here? What's associated with each hemoglobin molecule? An iron, right? So there's going to be 4 irons. So 4 irons for each of those 4 heme molecules. So this is the correct answer. It's not just 2. It's a total of 4. Make sense? Okay. Next one here. We didn't talk about this yet. I'll let you go ahead and answer it. We're going to talk about this next time. But since we already started it, whatever. So if you didn't get it right, it's okay. Don't worry. By Thursday, this should become more and more clear to you all. The majority of you guys got it right. So if you have A, type A blood, that means you're going to have A antigen. That means you have anti-B immunoglobulins. Okay? Anti-B antibodies. Does that make sense at all? It's okay. If it doesn't make sense, we'll talk about it on Thursday, so no big deal. So in other words, we will continue the last of these questions halfway through next time we meet, and then we'll complete this portion of Chapter 18 on Thursday. You guys have any questions? No? Cool. All right. Well, enjoy the rest of your day, and I'll see you all on Thursday.